Good morning. I would like to introduce Eva Breuer. She's a third-year resident in our department. And in 2017, she spent, due to her scientific interest, 6 months in the laboratory and will return there next month. The topic from this morning is human papillomavirus infection in the ANA region and treatment options.
Thank you very much for this introduction. Today, as said before, I would like to talk about human papillomavirus infection. It's a subject that is very important as there are a lot of cases. So the human papillomavirus is a virus that is mostly causing warts. That's what we see. That is called Condylomata acuminata. It's spreading mostly genital, but it can also be present on the skin. It can go to the oral cavity, sometimes after childbirth, and also during oral sexual behavior. Today we would like to talk about the anal infections with a human papillomavirus. It's a sexually transmitted disease, and about 80% of us and of the general population will be infected with the virus once in their lifetime. We have 1/3 of all the sexually transmitted diseases are Hpv virus. In most of us, the virus will be eliminated within 1 and 2 years because our immune system fights against the virus. And we know, or the virus itself was in focus or is in focus because it's a risk factor for cervical cancer, and it's also a risk factor for anal cancer. So we assume that about 90% of all the anal cancers are due to an infection with the human papillomavirus. So the history of the virus is as old as mankind. This is an older picture of Condylomata acuminata, but we know that already in the Bible there are passages where they describe an infection with the human papillomavirus. They talk about emeralds, but the historians, they believe that this is an infection with the human papillomavirus. We can also make historical research with the virus because we know there is a Hpv-16 infection in our ancestors, and we know that the Neanderthal people, they had the strand A and they brought it to Europe, and we know that actually the modern human never had sexual contact with the Neanderthal people, but we have this strand A also in our population. So we assume, due to this research, we assume that some of the Neanderthalers, they had sexual interaction with our modern ancestors. What are the symptoms of an infection with the human papillomavirus? Question to the residents.
Warts, itching, pain.
Yes, yeah, more or less that's the case. The symptoms are actually, an infection itself has no special symptoms. Some people have this itching, some have pain. The pain and the itching starts when there are warts, when the warts, they grow bigger, sometimes into a Buschke-Löwenstein tumor. We will see pictures after, but only if the infection is advanced, there is the pain, is the itching, the bleeding, and if it goes further to an anal cancer, then also the changes get more worse. These are pictures. We see these very typical warts and these groups of bumps, usually in the genital area. Here we can see it in the perianal region. If it gets bigger, it can be a Buschke-Löwenstein tumor, mostly in immunosuppressed patients, in patients with AIDS or that are infected with the Hpv virus. The cancer itself starts with the condyloma, then goes into an anal intraepithelial neoplasia, and then to anal cancer. So it makes this progression, but not directly. It goes first into a low-grade neoplasia, then high-grade, then into a carcinoma in situ, and then to the anal cancer. So we know that this progression happens, and we know more or less how it happens. The risk factors for a infection itself with a human papillomavirus are known. We have a lot of studies for this infection risk. We know that a high lifetime number of sexual intercourse, sexual partners are a risk factor. The more you have sex, the more you have the risk for getting the infection. Anal intercourse is a risk factor for the anal infection with the virus. We have men that have sex with men is a high risk factor for anal HB virus infection. Also the immunocompromised patients with transplant patients, HIV positive patients. Cigarette smoking is a risk factor, drug use, and also people that already had some kind of human papillomavirus infection and cancer due to this. The incidence of the cancer coming from the human papillomavirus is quite low. It's only one in a population of 100,000 people. But if we take a look at the subpopulation of the HIV negative men, homosexual men, then it rises, and it rises more if they are infected with the HIV virus. Then it goes up to more than 100 in a population of 100,000, and it's quite high. The virus itself is a DNA virus. The human is the only reservoir for the virus. We don't have it in other species. Most important is that there are about 100 subtypes. Some of them are low risk. They only cause the warts. That's nasty, but it's not a real problem. But we have the high risk types, like 16, like 18, and they can cause cancer. They are known to cause the cervical cancer, but also anal cancer. How do we diagnose the virus? Because there are other things that make things there. Some things like fibroma, they are known. They happen also in other places of the body. But a question for the residents, do you know what this here is? This here?
Hemorrhoids? No?
Yeah, or Morisken in German, these anal tags. We have here molluscum contagiosum. It's also something that happens. And here we have a case of syphilis. And we have to distinguish between these infections. So if we suspect a human papillomavirus infection, we ask for the risk factors. We discussed it beforehand about the sexual behavior. That's very important. We ask if is there a previous infection, maybe a woman with cervical cancer before. We perform a digital rectal examination, and we can make a Pap smear. It's like the gynecologist does it with a cervical Pap smear, but just anally. And the last part, and maybe the most important part for the diagnostics, is a high-resolution endoscopy together with acetic acid. So that's called as acetowhitening, and I will show some pictures. We see here is the transformation zone from the colorectal zone that forms the rectum up there, and from the squamous zone down here. And in the middle is this transformation zone that can be seen as thin line. And if there is a transformation of this area, it gets thicker, and that can be seen with the acetowhitening. So we just try to make it visible with acid. Here we can see some pictures. We look for the color, for the borders of these lesions, from the contour. We can see here it's like a little bit more shiny. Here we can see parts are raised. Here we cannot really see a border as clear as we saw before. Sometimes you see it's very, very flat, and it's all very suspicious for anal intraepithelial lesions or even cancer. Here are other pictures where the blood vessels are visible. Here we can see these little points. We can see striated lesions like here, and also mosaic patterns. That's very typical for an infection and for lesions. So as I discussed beforehand, the infection itself is a risk factor for anal cancer. The infection happens at the basal layer here and transforms these cells, and over the years there happens this transformation up. We have here this invasive carcinoma. That's not something that happens from one day to another. I can show this picture here. So We have years until we have anal intraepithelial neoplasia, and we have 10 to 30 years until we have a cancer. So it's not something that happens from one day to another, but needs some time to develop. In HIV patients, the risk for infection and for anal cancer is much higher. So if we take a look at our population, so we are negative, we have an infection rate of about 60%, and if we are HIV positive, it goes up until nearly 100%, especially when the CD4 count is very low. With the introduction of the antiretroviral therapy in the midst of the 90s, we thought maybe it gets better, because we know that due to the restoration of the immune system, we have a reduction of Kaposi sarcoma, we had a reduction in the incidence of Hodgkin's lymphoma, and so the expectation was also that anal cancer rates will decrease, but actually it did not. Anal cancer in these patients had a rise since then, and the explanation is kind of simple. These patients, they live longer, they survive their HIV infection, and therefore the human papillomavirus has the time to develop into a cancer. You might say, okay, anal cancer is something that is quite rare. Yeah, if we compare it with other cancers, it's rare. We have breast cancer, prostate cancer, where we have a huge incidence in our general population. But if you take a closer look at our patients of interest, the homosexual men and the people with HIV infection, then it's a different story. And we have here an incidence that is nearly as high as with breast cancer and prostate cancer. So for this population, it's a very important diagnosis. So transplant patients also, they have a higher incidence that's known for other cancers. Now, coming to the treatment, that's the most important part. The therapy depends on the patient. That's kind of logical. Older patients are treated different than very young patients. The tolerance of the patient is different, and the immune function. We have surgical therapies and we have non-surgical therapies. If we take a look at the surgical therapies, so here's the surgical treatment. One possibility is to just resect all the lesions. We can do that by shaving it off. We can perform electrosurgery or electrocautery. That can be seen here. We just pull these warts away, and then we can remove them. The resection is dependent on the growth of the tumor. Is it possible to just remove the warts, or do we have perform a wide excision of the lesions? We know that in HIV positive patients we can also perform a resection, but we have higher recurrence rates than in patients without the immunodeficiency. So some people say maybe it's good to make surveillance better than just resect everything we have. Another possibility is the laser therapy that is performed here regularly, where the lesions are kind of burned away with a CO2 laser. That's a very elegant way to remove these warts, as can be seen here. Here it's important to know that the laser does not go into the depth. It's, if we have intraepithelial lesions, sometimes we cannot reach them. It leaves no scars, and it's important to protect, or the surgeon has to protect himself, as there are virus particles in the smoke of this laser smoke. There's also the possibility of infrared coagulation, but also here the recurrence rate after the first treatment is high. It goes lower if we perform it regularly. And there is the possibility of cryotherapy, meaning we just burn it away with cold. There's also a non-surgical possibility of treatment. It's called Aldara cream. It's not really known how exactly it works, but it's known to make an immunomodulation. We have good data about that, but the recurrence rates are quite high, and usually it's not performed as a first-line treatment to remove the warts, but as a treatment after the surgical removal of these warts to lower the incidence of recurrences. As the problem is also that the disadvantages of this therapy are quite high. A lot of people have problems with itching because of the cream, with pain, with erosions, erythema. So we have to discuss the use of this cream. So it needs to be performed during the night, during several weeks after the resection of the warts, and then we can use it as a post-treatment adjuvant. Not a first-line therapy, but an adjuvant to the resection. So actually these are the therapies, how to remove the lesions. But as said before, recurrence is quite common. We have here in homosexual men a study where they looked at all the HIV negative people, and about 1/3 of all the patients had a recurrence within the next years. The time to recurrence depends. Some recur quite early, some later, and we do not have any risk factors for recurrence. So surveillance after resection of these HPV-related warts is key of the treatment. One key of the treatment or of the management of the disease is the prevention. So use a condom. That's something we can tell our patients to prevent in first hand the infection. And we have a vaccine that is used since 2007 in Switzerland for the prevention of Hpv infection in young girls to prevent cervical cancer. It protects, the newest version of this vaccination protects against 9 different subtypes of the human papillomavirus, and it's recommended for all the girls, and since 2015 it's also recommended for the boys, as they are vectors for the disease. They can transfer the virus onto the women, and they can also get anal cancer, as I told you before. Are there screening programs? No, actually not really. We have good screening programs for cervical cancer or cervical lesions, but not for the anal lesions. But we have some groups. Yeah, they make practice guidelines, and more or less all of them say screen the high-risk patients, so all homosexual patients that have sex with men, all the patients with anal intercourse. That's more or less the basic message of all these guidelines. So that means physical examination, if possible, every year. Also every year a pap smear. For all the patients with or without HIV, and especially all those patients that had an infection and had cancer before, also to control them regularly. The screening program we perform here, or we try to tell the people, is yearly or more or less yearly. Screen with a high-resolution endoscopy, with an anal pap smear, sometimes with biopsy, and if there is something visible, we try to make a cryoablation. The follow-up depends on if it's a high-grade lesion or it's a low-grade lesion after resection of the warts. And to make a conclusion about this subject, as I told you in the beginning of the talk, there is this progression from infection, condyloma, into the anal intraepithelial neoplasia, into an anal carcinoma. And immunosuppressed patients are at risk. It's important to look for this disease if you have a suspicion in patients, especially if they have risk factors, and we have to ask for them. And the therapy depends on the patient, but is mostly excision and surgical resection of these warts. of these lesions, and the screening and close follow-up for patients at risk. And these are the HIV positive, these are the patients with anal intercourse. That's more or less everything. Yeah, I would like to thank you for your attention. Do you have any further questions?
Thank you very much, Eva. Excellent presentation. A very nice summary of the important topics for HPV infections. Any questions from the audience?
Thank you very much for your presentation. Should we treat our patient after surgery with Aldara cream as a prophylactic therapy for recidive?
Yeah, this is performed regularly here, yes, as a recurrence prophylaxis, yes.
Obviously, it looks like CMV, where you have a high prevalence, right? But I also saw that 70 or 80% can eliminate the virus. Is there any serological test, which I did not hear, like we have it in hepatitis B, C, HIV, where you know you had mild contact, but you eliminated the virus, where you probably can better monitor instead of looking with a loop or something?
Eva has shown that in the beginning there is dozens of serotypes of HPV that can cause HPV infections. However, there is a number that is more common, and then there's only some HPV serotypes that are more likely to cause cancer than others. Typical high-risk serotypes are numbers 16 and 18, 31, 33. There is a number of serotypes such as 6 and 11 that are mainly responsible for causing warts, and the development of warts does not imply or is not necessarily associated with a high risk of the development of cancer, so it needs to be kept apart. Now, we do not routinely analyze serotypes in all HPV patients because it makes no sense and it costs money, but there is a way to do that, and for some distinct questions we can actually do that. When do you do serotyping in your patients?
I do it in risk patient with recurrence infection.
I have a comment to make regarding immunization. You were talking about immunization. That's something that has come up only recently. And in Switzerland, since 2016, health insurance companies will pay for immunizations for all children between 11 years and adolescents and adults to 26 years. And that's irrespective of gender. And if we really wish to combat this disease, that's what we need to do for the next generation. So have your children immunized against HPV. There is at least 3 different types of immunizations out there. The one that is most favored is a immunization that goes against 4 different, it's against the 4 most important serotypes, and it is very effective in eliminating HPV-associated cancer in women. That's been shown, and more likely the same effect will go true for males. So have your children immunized yourself. It may not make a difference, but have your children immunized against HPV. A strong message we want to make today.
Yeah, I also started to recommend an immunization in patients who have really recurrent infection, where I have no option, where I take them all the time to the ORA. There we started to make an immunization, and this works. Sometimes they really have good response rate. And also the colleagues from the infectiology, they start to do it on the Hpv patients.
Thank you very much.